Welcome to part 2 of 2 presentations on the elbow. In this one we start with the nightstick fracture of the ulna, and then we go on to Monteggia and Galeazzi fracture dislocations of the forearm, and then spend the rest of the time focusing on paediatric fractures.
A nightstick fracture is an isolated fracture of the ulna. It's so called a nightstick fracture after people who, being chased by the local constable, would put up their arms to protect themselves as the constable would go to strike them with their truncheon. And this self-defensive move would result in an isolated fracture of the ulna. The important thing to note is that the distal radial ulnar joint is intact. There's no dislocation or subluxation. If the ulnar fracture was grossly displaced, it would probably result in a disruption to the drudge. And so therefore, by definition, nightstick fractures are usually only slightly displaced, or even in some cases not displaced at all. When we talk about fractures of long bones, we divide the diaphysis. So the diaphysis is the long tubular portion, and we divide the diaphysis into the proximal, middle and distal third. So here we can see that we have a fracture involving the distal third of the diaphysis of the ulna. Once the diaphysis starts to flare, this is the metaphysis. And when you get down to the distal portions of the long bones, you can start to be quite specific with regards to fracture locations. So we only refer to the distal third or the middle third or the proximal third, or even at junctions of the middle to distal third, or so on and so forth, when it comes to the diaphysis. So it's important when you have fractures at specific bony landmarks that you actually use the correct terminology to describe the anatomical location. Because this fracture has an eponymous name, it's important that in the what you use that name to describe the fracture. So what is it? It's a nightstick fracture. Where? It's the distal diaphysis of the right ulna. How? Slightly displaced. A Galeazzi fracture dislocation is a fracture of the distal radius with dislocation of the distal radial ulnar joint. In order for the drudge to dislocate, there has to be marked displacement of the radial fracture. We can see here that if we know that our radius is on our lateral aspect and the ulna is on the medial aspect, we can see that the distal fragment of the radius has displaced laterally with marked overlap of the two fracture fragments. If we look, we can see the head of the ulna, which has no relationship to the distal radius, and therefore we can tell that it's dislocated. Now let's look at the Galeazzi fracture dislocation from the lateral aspect. Remember, we always talk about the distal fragment in relation to the anterior portion. So with the lateral view, this is our anterior surface and this is our posterior surface. And we can see that the fracture fragment of the distal radius has marked anterior angulation. And here we can see that the dislocation of the distal ulna has displaced or dislocated posteriorly. So what is it? It's a Galeazzi fracture dislocation, where it's at the junction of the mid to distal third of the radius, that's the fracture, and we've got dislocation of the distal radioulnar joint. So how is it? Well, our fracture has anterior angulation and lateral overlap. That's important to comment on the overlap. And the dislocation has got posterior dislocation. The paediatric elbow can be really very tricky, and that's because there are numerous ossification centres. So we use the mnemonic tritol to help remember the order they appear at. So C is for capitulum, R for radial head, I for internal or medial epicondyle, T for trochlear, O for olecranon, and L for lateral epicondyle. The way to remember the ages that they appear at is that they appear on every odd year. So the capitulum is at 1, the radial head at 3, the internal epicondyle at 5, the trochlear at 7, the olecranon at 9, and the lateral epicondyle at 11. And generally they tend to fuse between the ages of 13 to 16 years of age, but that is dependent on both the gender and the age the child reaches puberty. The most important thing that I want you to remember is that the trochlear never ever appears before the internal epicondyle. The internal epicondyle must always appear before the trochlear, always. And that's a really important thing for you to remember, and we'll cover that in a bit more detail in a moment. Here we have an 11-year-old child with all the ossification centres visualised. So C is our capitulum, R is our radial head, I is the internal epicondyle, T is the trochlear, O for the olecranon, and in this case they've used the letter E instead of L to represent the lateral or external epicondyle. On the lateral view, our capitulum superimposes the trochlear. Then we have R for our radial head, I for the internal epicondyle, and as I said, the trochlear is superimposed by the capitulum, O for the olecranon, and again the E is also superimposed by the adjacent bones. So there's a few things that I want you to understand. The lateral or external epicondyle, the olecranon and the trochlear are frequently multi-fragmented, and this multi-fragmented appearances of the ossification centres is normal and must not be misconstrued as an injury. The medial epicondyle or internal epicondyle is smooth and rounded in appearance, and it is superimposed over the adjacent host bone of the humerus. Conversely, the lateral or external epicondyle, it is projected away from the host bone of the humerus, and in some cases, because of the diverging ray of the radiation beam, it can appear projected quite some distance from the adjacent host bone, and that mustn't be misconstrued as an injury. So the medial epicondyle superimposes the host bone, whereas the external or lateral epicondyle does not. Let's have a look at this paediatric elbow of the lateral view. Here we have our supracondylar ridges, and these form together to form the fossae, the olecranon fossae here posteriorly and the coronoid fossae anteriorly. And the olecranon fossae allow the olecranon to fit into here when the elbow goes into full extension. Conversely, when the elbow goes into full flexion, the coronoid process can fit into the coronoid fossae. We can see our anterior fat pad, which is a normal, dark, small triangular line that lies anterior to the anterior humerus. And remember, because the posterior fat pad is in the olecranon fossae, we can't see it. This appearance of the supracondylar groove coming close together to form the olecranon and coronoid fossae creates the appearance of an hourglass. Now, the important thing to understand with a supracondylar fracture is that it always involves the foci. So when you look at a paediatric elbow, pay close attention to the waist of the hourglass, because frequently you will see a fracture through there, or if there is disruption to the hourglass, that can help you guide you towards an underlying supracondylar injury. Supracondylar fractures displace posteriorly, and so we use the anterior humeral line to assess for posterior displacement. A normal anterior humeral line is a line that is drawn down the anterior cortex of the distal humerus, and this anterior humeral line will bisect the capitulum through the middle third. If you have a posteriorly displaced supracondylar fracture, what will happen is that the anterior humeral line will end up bisecting the capitulum through the proximal third. And in the cases of grossly displaced supracondylar fractures, it may even appear anterior to the capitulum. The only time that this is not very accurate is in extremely young children, when there's not enough ossification of the capitulum to be able to adequately assess the anterior humeral line. But don't worry, we won't give you something that tricky in the exam. The Radiocapitella line helps us to evaluate the relationship of the radial head with the capitulum, and this is particularly important for Monteggia fracture dislocations, where you have a dislocation of the radial head. Now, a radiocapitellar line should only be drawn from the radial neck. These pictures are actually incorrect. The reason being is, and this is a good example with picture A, we can see that the radial neck then angulates when it moves on to through to the diaphysis. And so if you take the midpoint from the diaphysis of the radius, you can actually get a skewed impression of a dislocation. So when you draw your radiocapitellar line, it should be from the middle of your radius, no distal than the radial neck, and that line should then be drawn up through the radial head into the capitulum, and it should bisect it. It doesn't always become very accurate with incredibly young children. We can see here in picture D that actually this radiocapitellar line, which is far too long, it should only be from here, actually doesn't bisect the radius in the midpoint. So actually I think that's a little bit inaccurate. But certainly A, B and C are good examples of a radiocapitellar line showing a normal relationship. A Monteggia fracture dislocation is a fracture of the proximal ulna with dislocation of the radius. This patient has been imaged so that their elbow joint is in a lateral position whilst their wrist is in a PA position. So let's orientate ourselves. Let's look at the elbow aspect. So the radius, this is going to be anterior, whereas our ulna is posterior. When you now look at the PA view of the wrist, the radius is in the lateral position, whereas the ulna is in the medial position. Okay, so let's look at this a little bit more closely. Remember, we use the radiocapitellar line to evaluate the relationship of the radial head with the capitulum. So let's draw in our radiocapitellar line. Remember, this line should be drawn from the midpoint of the radial neck, and it should bisect the midpoint of the head of radius and then through to the capitulum. And we can quite clearly see that the radiocapitellar line has nowhere near the capitulum, and therefore we have a dislocation of the radial head. Now Now let's look a little bit more closely at this fracture. We know that this is lateral and this is medial, and we know that this is anterior and this is posterior. So we always describe the distal fragment in relationship to the proximal fragment. So by looking at this, we can see that the ulna has displaced both medially and posteriorly with marked angulation. Okay, so what is it? It's a Monteggia fracture dislocation, where it's at the junction of the proximal to mid-diaphysis of the right ulna, that's the fracture, and the radial head, which is the dislocation. So how is it? Well, you've got posterior medial displacement, and remember, you've got significant overlap of the fracture site, and you have an anterior dislocation. Now let's look at supracondylar fractures. These are the most common injuries to the paediatric elbow. We can clearly see that this is the medial epicondyle and this is our lateral epicondyle. And with our supracondylar fractures, they always bisect the coronoid and olecranon fossae. So we can see this transverse line bisecting the supracondylar region. Now let's look at the lateral view. Remember, we use the anterior humeral line to assess for displacement. So if we draw the anterior humeral line which runs along the anterior cortex of the distal humerus, it should bisect the capitulum through the middle third. And here we can see that the capitulum does not run, the anterior humeral line does not run through the middle third of the capitulum, instead it passes through the proximal third of the capitulum. Therefore, we know that there has to be a supracondylar fracture with posterior displacement. Remember when we talked about the hourglass shape of the supracondylar ridge coming down to form the fossae, and we can see that there is a little line that passes through this region. So what else do we have to look at with our elbow joint? Yes, that's right, it's our soft tissue signs. So we can see we've got a significant elbow joint effusion with marked displacement of the posterior fat pad, as it's the joint effusion has caused the posterior fat pad to be pushed out of the olecranon fossa and to be visualised as the dark grey structure to the posterior aspect of the distal humerus. And here we can see a very small but still significant elevated anterior fat pad. So we've got a positive soft tissue sign, we've got an abnormal anterior humeral line, and we can visualise the lucent line passing through our supracondylar region, indicating that we have a supracondylar fracture. So what is it? It's a fracture where it's the supracondylar region. How? Mild posterior displacement. We can say there's mild posterior displacement because the anterior humeral line still bisects the capitulum, as opposed to a more significant displaced supracondylar fracture where the anterior humeral line won't even bisect the capitulum at all. Fractures of the lateral condyle are the second most common fractures in paediatrics of the elbow. It's important to remember that when you look at a paediatric elbow, we see this unossified cartilaginous structure and might be fooled into thinking it was just soft tissue. It's not. It is cartilaginous and it's just not ossified. So when you get a fracture through the lateral condyle, sometimes they're incomplete, so they're just a very small fracture line at the lateral aspect, whereas sometimes they can extend all the way through to the articular surface of the unossified cartilaginous region. If they did extend all the way out to the ossified cartilaginous region of the articular surface, this then becomes a Salter-Harris 4 injury. You can get gross displacement of the fracture site, and in some cases it can end up being completely rotated. However, if you see this image of the central picture where you can't actually see it extending out into the articular surface because it's not ossified, I wouldn't be expecting you to comment on it being a Salter-Harris 4. However, if you see displacement of the lateral condylar fracture with the capitulum articulating with this fracture fragment, then you could call it a Salter-Harris 4 injury. Fractures of the lateral condyle are the second most common paediatric fracture of the elbow. So if we look, we can carefully see a lucent line bisecting the lateral epicondyle. It's important to remember critol to ensure that we don't misconstrue this appearance as a secondary ossification centre. So here we have the capitulum, here we have the radial head, and here we can see the medial or internal epicondyle, and we can quite clearly demonstrate that there is no ossified trochlear. Therefore, this cannot be the lateral epicondyle and must be a fracture. So what is it? It's a fracture where the lateral condyle, how, undisplaced. Here we have another fracture of the lateral condyle. We can see there is gross soft tissue swelling, and we can see that there is a distracted fracture through the lateral condyle. Importantly, we can see that the capitulum is still in alignment with the fractured lateral condyle, and so therefore this entire portion has broken off and has been displaced laterally. Because we have marked displacement, we can then tell that this fracture through the lateral condyle extends through the unossified cartilage to the articular surface, thereby forming a Salter-Harris 4 fracture. Remember, a Salter-Harris 4 fracture is a fracture that extends through the metaphysis, the physis, and the epiphysis. So we can clearly see that this is a Salter-Harris 4 injury. So what is it? It's a Salter-Harris 4 fracture where the lateral condyle, how, lateral displacement. Medial epicondyle avulsion injuries are usually a traction injury caused by a valgus force. And what happens is that you get varying degrees of avulsion of the medial epicondyle. In the worst case scenario, the medial epicondyle becomes entrapped within the humeral-ulnar joint. This is why it's so important to use critol when you're assessing the elbow joint, because if you don't, you can mistake the entrapped internal epicondyle for the trochlear, and this can have a catastrophic effect on the patient, as this entrapped epicondyle will eventually become necrotic and there will end up being destruction to the joint. Let's have a look at the medial epicondyle and become familiar with the normal appearance. If you remember, the medial epicondyle is a rounded structure that superimposes the adjacent host bone. Look at the normal shape of the outline of the medial epicondyle and you can see that it's smooth and rounded. Let's now compare it with this image on the right of an entrapped medial epicondyle. If you look at the host bone at the adjacent site of where the medial epicondyle should sit, we can see that there is a squaring off, indicating that this is abnormal and that the smooth, rounded medial epicondyle has become avulsed. You can also recognise the gross soft tissue swelling associated with this significant trauma. Okay, let's look at this other example. We can see that we have a squared off appearance to the adjacent host bone of the distal humerus, and we can see that the smooth outline of the medial epicondyle has become distracted away from the adjacent humerus. We can even see a small fracture fragment associated with it. Again, look for the soft tissue signs. There's gross soft tissue swelling. Unfortunately, the medial epicondyle is extracapsular, so that means that you won't actually see an elbow joint effusion, as this occurs outside the joint. So looking for an elevated anterior fat pad and a posterior fat pad sign on your lateral view won't help you. So what is it? It's an avulsion injury and fracture where it's the medial epicondyle. How? Slight distraction with a small fracture fragment. Here is another example of an avulsion of a medial epicondyle. And here we can see that there's much greater distraction of the medial epicondyle. So once again, look at this squared off appearance of the adjacent humerus, as there is no longer the smooth rounded structure of the medial epicondyle superimposed over it. And here we can see another tiny sliver of an avulsion fragment. The gross soft tissue swelling helps to indicate that there is a significant injury underlying here. Here is another example of a medial epicondyle avulsion injury, but this one is demonstrated on the lateral view. Now, I said previously that medial epicondyles are extracapsular and therefore you don't necessarily get a joint effusion with it. However, in this particular instance, there must be some disruption to the capsule because we have an elevated anterior fat pad representing a sale sign and a posterior fat pad. So quite clearly there has been an injury within the joint capsule to cause this joint effusion. Now, it can be quite difficult to see an entrapped medial epicondyle on the lateral, so it's important to recognise what the different densities represent. If we look carefully, we can see that we have this semi-circle representing the capitulum, and if you look carefully, we can see this rounded increase in density just superimposed over the inferior portion of the capitulum, and this rounded increase in density is the entrapped medial epicondyle. On this single view, we can't actually see a fracture, and so therefore when we discuss the what, we need to make sure that we say that there is an avulsion injury because of the entrapped medial epicondyle, but we need to also mention that there is a joint effusion as well. If you have a very clearly demonstrated fracture within the intracapsular region of the elbow joint, you don't need to discuss a joint effusion because you've identified the abnormality. Not all injuries to the elbow joint are visible on the first presentation, which is why if you have a normal bony appearances but there is an abnormal joint effusion, you need to discuss that, because what that means is that an occult fracture must be suspected. So in this particular instance, although we can't see a fracture, we know that there is a joint effusion, so an underlying fracture must be suspected on this single view. So what is it? It's an avulsion injury and a joint effusion. Where? The medial epicondyle. How? Entrapment within the joint. Okay, let's look again at the AP view of a patient with an entrapped medial epicondyle. We discussed earlier about how you have the squared off appearance of the adjacent host bone of the humerus and how you can see that the rounded epicondyle lies within the humeroulnar joint. But let's have a look at the alignment of the joint. If we look carefully, we can see the trochlear here, followed by the capitulum, and then we can see the articular surface of the head of radius and the ulna, the coronoid process. What we can see here is that we have diastasis of the humeroulnar joint, whereas you have normal joint space width of the humeroradial joint. And this diastasis means that there has to be entrapment to cause that prevents the joint from closing back normally. Okay, let's look at another appearance of an entrapped medial epicondyle. This is a dedicated radial head view. We don't tend to do these anymore because it's not actually necessary. As I've said, if you have an elbow joint effusion but no evidence of an obvious fracture, you have to still suspect an occult fracture, and therefore you don't need a further view because you're managing the patient clinically as though they have a fracture. And it's when they come back for fracture clinic images that quite often you'll see the occult injury becomes apparent. Okay, let's look again. We can see quite clearly this rounded increase in density of the entrapped medial epicondyle. So it's always important that when you look at the elbow joint to be able to identify the different bony structures so that you don't overlook it, because it can be quite subtle. So what is it? It's an avulsion injury, where it's the medial epicondyle. How? It's entrapped within the joint space. Whilst not particularly common, paediatrics do suffer from radial neck fractures. And so what we're looking at is just a sharp angulation of the normal smooth contour, and we can even see a tiny break within the cortex. And so this is the classic appearance of a radial neck fracture in a paediatric. So be careful to check carefully. So when you do your image for your AP elbow of the paediatric, and on your first view you should have the distal humerus in contact with your receptor, because most paediatrics sustain a supracondylar fracture, with the second most common being a lateral condylar fracture. So if you can exclude that there is no supracondylar fracture, no lateral condylar fracture, you then need to go on and do a second AP with the proximal radius and ulna in close contact with the digital receptor, so that you get a good visualization of the radial neck and proximal ulna, just to make sure that you haven't overlooked a less common radial neck fracture. So what is it? It's a fracture where it's the radial neck. How? It's minimally displaced. This is another example of a radial neck fracture, and this is a Salter-Harris injury. So remember, the radial neck is your proximal metaphysis. We can quite clearly see our physis, and the radial head forms the epiphysis. Now with this particular injury, we can see the fracture of the metaphysis that extends to the physis. So we know that a fracture of the metaphysis which extends to the physis is a Salter-Harris 2 injury. But you also have a slip of the physis off the opposing bone, and so therefore a slip through the physis means there must be a horizontal fracture running through the physis, which is a Salter-Harris 1 injury. So in this particular example, we actually have an example of a Salter-Harris 1/2 injury because we have a fracture through the metaphysis and associated lateral slip of the Salter-Harris 1 injury. So what is it? It's a Salter-Harris 1/2 fracture. Where? The radial neck. How? It's a slip with severe lateral angulation. A pulled elbow, otherwise known as a nursemaid's elbow, it occurs in patients between the ages of 2 to 5 years. And what happens is the forearm is held in mid-pronation. What happens with this injury is because the annular ligament is very lax and it doesn't adhere tightly to the adjacent bony structures, it slips over the radial head and then becomes entrapped within the joint. And so therefore you might think there may be diastasis of the joint, but because the annular ligament is so slender, you won't see any diastasis. And what happens is that with a pulled or nursemaid's elbow, this annular ligament moves back into the normal position when you supinate the forearm. So basically, by putting your patient into an AP view, you will then reduce the injury. And so classically, you get normal appearances of the radiographs.